Hemorrhoids are vascular cushions present at the anus or in the distal rectum, at the very lower aspect of the bottom. They're common. We know that over 50 to 70% of the adult population, at a conservative estimate, have hemorrhoids. The best analogy I can think of is to consider sort of grapes or strawberries at the base of your bottom that come in and out of your bottom. And they can present with bleeding from your bottom, the suggestion of a lump in your bottom, itching, and occasionally pain in your bottom as well. But they are very common. So the main cause of hemorrhoids, I'd say, is a straining at stool, the inability, for example, to go to the toilet on a regular basis, and thus initiating this concept where you have to sit in the toilet for perhaps 10, 15, perhaps even 20 minutes. And in some individuals, perhaps a 30 to 40 minute time frame where they're continuously straining on the toilet. So that's the commonest cause. It's a disorder primarily of defecation, but it's an extremely common one. And it's also more common as we increase in age. It's much more common in women, especially following childbirth. Treatment is required when your symptoms, depending on what your symptoms are, tend to deteriorate. But however, there's certain symptoms that should be assessed and brought to the attention of your GP or your doctor, whether that be a surgeon or a physician. So the symptoms that require investigation are rectal bleeding. So just because you see blood in the toilet paper or in the toilet pan, it doesn't mean that you necessarily need to rush to the doctor at all. But I think it is something that needs investigation, especially as we increase in age. So, especially if you're over the age of 35 or 40 years of age and you experience bleeding, and if that's associated with any alteration in your bowel habit, then you should certainly see a doctor and obtain a colonoscopy to ensure there's no other cause for the bleeding, as opposed to just hemorrhoids alone. Thereafter, if, say, for example, you're experiencing a lot of discomfort or the hemorrhoids are prolapsing out of your bottom, then those are the sort of primary indications for intervention. So to summarize, if you have very little in the way of symptoms, apart from bleeding, the most important concept is to exclude an alternative cause of the bleeding. If, say, for example, you're having bleeding plus your hemorrhoids are coming out on a regular basis, then you require, in addition to colonoscopy, some further treatment to the hemorrhoids. I tend to adopt a fairly conservative approach to the management of hemorrhoids. So if the symptoms are not too debilitating, we can consider normal sort of natural factors such as a laxative, ensuring that you're having a healthy diet, drinking plenty of fluids, etc. However, should your symptoms involve a prolapsing lump in your bottom and you have to manually push them up, or you're experiencing discomfort in your bottom, in addition to bleeding, then in my opinion, the best option available is something like a hemorrhoidal band. And the concept of that is, for example, it's like a rubber band. And if you imagine a grape that's coming in and out of your bottom, you apply a rubber band that's like a lasso onto the junction between the grape and the stalk of the grape. And after 5 days or so, the hemorrhoid will naturally fall off because the blood supply to the hemorrhoid is constricted. So that's my preferred option. And I prefer that to injection sclerotherapy because it's less painful. And the outcomes I find, or the evidence suggests, that the outcomes comparing hemorrhoidal banding to conventional hemorrhoidal surgery, such as hemorrhoidectomy, are similar at 12 months. And there's no requirement for a general anesthetic. That's the other advantage. There's no general anesthetic. You come into the clinic, and it's something that can take place within a couple of minutes, as opposed to hemorrhoidectomy, which requires 30 minutes and a general anesthetic and a sore bottom afterwards. Good question. So I would say yes, to an extent. I tend to favor conditions where patients that have got significant hemorrhoidal prolapse or have recurrent hemorrhoidal symptoms. I've often seen patients that have had hemorrhoidectomies over a course of 10, 15 years, and they've come and said, look, I think I need my third or my fourth hemorrhoidectomy. And I say, look, let's do a colonoscopy to ensure that the bleeding that you're experiencing isn't coming from an alternative cause. And then assuming the colonoscopy is normal, we can put a band on the hemorrhoid. And then what I tend to advocate is something like biofeedback therapy, which is essentially pelvic floor physiotherapy. Now, in the past, it's been reserved primarily for women that have had children and where the pelvic floor isn't quite what it used to be. But I find that pelvic floor physiotherapy, especially in patients with recurrent hemorrhoidal symptoms who have to strain to go to the toilet, combined with hemorrhoidal banding, which is a fairly non-invasive method of managing hemorrhoids, is a very successful means of obtaining a good long-term symptomatic outcome. And it's also reproducible, i.e. if you have a recurrence of your symptoms in, say, 12 months or 18 months or 2 years, you can undertake the hemorrhoidal banding again. I think if all conservative measures have failed, if you've got, for example, recurrent hemorrhoidal symptoms that are proven refractory to hemorrhoidal banding, or injection sclerotherapy, or other conservative methods than surgery is indicated. However, I think compared to when I first started, say, 25 years ago, the requirement for surgery now is reduced considerably. And some people sometimes turn around and say, look, I had terrible severe pain, I had thrombosed hemorrhoids. Do you think I'm going to need an operation at some stage? And I said, look, in my opinion and in my experience, people that have had severe thrombosed hemorrhoids, it tends to be a one-off event. And that doesn't necessarily mean that the symptoms are going to deteriorate again thereafter. So I'm very comfortable managing people conservatively, non-operatively, through whatever means required, primarily hemorrhoidal banding, and reserving surgery primarily for those patients, which are a very small cohort of patients that may eventually require hemorrhoidectomy.